Hello and welcome to Health Talks with Dr. Raina Mittal, where we dive into practical, empowering conversation about health and lifestyle. I'm Dr. Raina, a GP and a health coach with a passion for helping women thrive at every stage of a woman's life. Today's episode is a part of our Women Health series, and we are starting an important conversation in fertility. Fertility concerns are becoming more and more common in GP clinics, and we are referring many couples to fertility specialists. But what exactly is infertility? When should you seek help? And what considered normal when trying to conceive? To help us unpack the basics, I'm joined by Dr. Smriti Bhatta, an experienced infertility specialist based in Aberdeen, Scotland. She brings a wealth of knowledge and compassion to this topic. In this episode, we are focusing on the clinical basics, but don't worry, we are just getting started. Hello, Dr. Smriti Bhatta.
Hello.
It's great to have you on, and especially excited because it's my first podcast. So we are talking about this for a while, how to do this to empower women to aware of their own health and to know the facts and what all they can do by themselves before reaching out to a GP or to a specialist. So thank you again for coming and doing this for me.
No, thank you for inviting me.
And today I thought we are going to talk about infertility in general and a basic question what people have a doubt about it.
Yeah, sure.
So to start with, what is infertility in clinical perspective? What do you mean by it?
Yeah, so infertility has various definitions, but clinically there is a pragmatic definition, and that is that when does a couple kind of need to start investigations into it. Okay, so in the absence of any unknown cause or health condition which can affect their fertility, a couple who has been trying and having regular sex for 1 year and haven't managed to get pregnant should start fertility investigation. So that's the clinical pragmatic definition, which basically guides the couples to start investigating and looking it. Okay. Now again, in fertility, it's a spectrum, okay, which can range from subfertility to absolute infertility. So some couples will be on the various ranges in the spectrum, where absolute infertility can only be the case where either they don't have any eggs and they don't have any sperms. Thankfully, those proportion of couples are very few. So mostly will lie in a range where the investigations will point out towards what is actually the reason for their kind of specific issue, and then we manage accordingly.
Okay, that's quite nice to understand what could it be, and especially the definition makes it people clearer.
Absolutely.
What is infertility means. We are seeing it is on a rise at the moment. We know there are a few factors which are causing a rise, but in your perspective, what do you see are common causes for both men and women is making now infertility is a more common presentation to the GP land?
Yeah, so obviously there are many issues which are making the infertility to go up, and let me first discuss what the causes are and what can happen in a man and woman, and not to forget it can also be a combined cause.
Okay? That's right.
So it could be related to both the male and the female partner. But now we have couples who are in same-sex relationship also, so there obviously you will define fertility differently. So concentrating on couples where we are seeing a man and a woman, we have the problems in the man where they can have problem with their sperm, which can be related to the sperm count, which is the number of sperm, the number of the swimming ability of the sperm, which we call as motility, or the morphology of the sperm.
That's right. Yeah.
And that can be linked to any underlying medical condition or anything to do with their genital tract or urinary tract previous history, or sometimes we may not find a reason for why they have it. Okay. So obviously that's part of the discussion when we do their test, and we take it accordingly. In women, if you imagine the various reproductive organs, we can classify fertility according to that. So if we think of that the woman has, and things which are essential is a uterus, the ovaries, and the fallopian tubes.
Yeah.
So if we concentrate on that, the woman can have a problem within their ovaries, which can be linked to them releasing an egg every month, which is called ovulation problem.
Yeah.
Or they may have less eggs in their ovaries, or the quality of eggs may not be good, which happens with age.
Right.
Okay. Or they may have had absence of ovaries genetically, which is the cause, or they may have had ovarian surgery or any conditions linked to the ovary like endometriosis, which is affecting their ability to ovulate or produce good eggs.
Right.
Okay. Then if we come to the uterus, they may have a problem within the womb structurally or within the lining of the womb.
Right.
Yeah? Or they may have had infections or surgery on the womb, which is causing the implantation to not happen adequately.
Right.
And the third is, if you look at the fallopian tubes, it may be that previously due to any surgery or any pelvic infections or any other causes, the fallopian tubes may be blocked, one or both. And again, that will reduce their capacity to, have babies. So these are kind of the broad ones. And then obviously there are very narrow minor ones, which is in terms of their reproductive hormone balance, which controls how you ovulate and how your lining develops and how a baby implants. Okay, so therefore all the investigations that we do are focused on finding where the actual problem is and then deal with it.
So obviously women have much more problems could have caused to the infertility than the men's are.
Yes, because in a man, with the only test we can do is a semen analysis, and the rest is down to their kind of physical condition and genitourinary makeup. And the other things we can do for men where we do find a low sperm count is we can assess why it is. So we can do genetic tests for them as well as their hormonal profile. So again, that can be linked to their sperm count. So for men, it starts always with the routine semen analysis. And then if we do find a problem in that, we move forward and do further tests for them. Okay. But in women, obviously at the outset, we are trying to assess all the aspects of that care and see whether there is an issue anywhere. So it's kind of a composite diagnosis.
So can you ever define like how much you find infertility is in a couple is mainly by the women cause or how much is by the male causes? Do we any percentage of that?
We have actually, because now the male fertility, and this is obviously maybe surprising to some of you, is on the rise, and at least half of the cases, 50%, are down to male infertility.
Yes, okay.
In females, the ovulation factor is the predominant one, and that accounts for 25 to 30% of cases.
Okay.
Then the tubal factor and the uterine problems account for about 10 to 15% of the cases. And the biggest factor in the female, which surpasses anything and can even kind of overshadow the male part, is the age of the female. Okay, because with age, even if the female doesn't have a problem structurally or otherwise, we know that the eggs do not have the capacity to perform adequately past a certain age, and that is as young as 35 years old. Okay, so and it's determined by their genetics as well. So this is something which is of absolute interest, and one of the key messages that I would want to convey to all the viewers and whoever is listening, that with age you cannot reverse fertility in females. So definitely the proactiveness regarding your fertility intent and your plans is absolutely vital, so that you get assessed early, know where you are in the fertility spectrum, because sometimes even the best fertility treatments won't be able to help you if we are dealing with the challenge of age on fertility.
I think that's really important, and I think that's a beautiful statement of saying that. But can you tell our viewers like what is the maximum age they can wait before they really have to do something about it? Like because at the moment people are waiting because of different reasons, because mostly for the career wise. So is there any specific age you say, like by the age of 32, 35, you should seek help or you should start thinking about doing something?
Yeah, absolutely. So in human females, the peak reproductive age group is between 20 to 30, when many of us are not even thinking or nearby planning a family.
That's so true. That might be shocking for the viewers.
Absolutely, yeah. So obviously, if you haven't had a chance to plan your family until then, we know that biologically your egg numbers as well as quality will start to decline from 30, and then it's in a more accelerated fashion past 35. And over 40, obviously the chances are very much reduced. So therefore, if you are trying, at least as I said, pragmatically for 1 year, and you're not managing, and especially if you're over 35, that timeline comes to under 6 months. Okay. So if you're under 35, you can wait up to a year, unless you have a known reason for fertility issues. But if in women over 35, it is the nice guidance that at 6 months you should be referred and start investigating for fertility, because the egg numbers decline and the chances of having a baby naturally or through treatment is actually better if you present early.
Yeah, I think you've already touched on how do we assess fertility in the secondary care. Is there anything as a GP can be done to assess the fertility in primary care before referring to?
Yeah, so currently what we do, obviously I've talked of all the tests, but in the primary care, while the couple are waiting, the GPs can test their reproductive hormones. They can test for the common sexual infections which can be linked to fertility. So they can do the genital or STI screening, and be proactive about screening, because sometimes women would not present. Okay, so essentially chlamydia screening is one that we recommend as a part of the fertility workup. And the third one, which is a very important hormone which can affect the reproductive hormones indirectly, is your thyroid hormone.
That's right, yes.
So because the GPs will have an opportunity before they're sent to secondary care, that if any thyroid issues are diagnosed, which we know is common in the subfertile couples, they can actually be managed early and timely, so that they're not wasting time after coming to secondary care and getting their thyroid optimized. That's because we will send them back to the GP to again get their thyroid optimized. Plus the ones GP can do is to have a good assessment of their medical conditions and optimizing that. So if somebody has, suppose say diabetes or any other condition which needs other specialist involvement, then to refer them appropriately, and even if they need pre-pregnancy counseling, to arrange that and then refer. So doing all this in the primary care, along with optimizing their weight, encouraging them to stop smoking, are all the things which will benefit us in secondary care. And more important, not us only, is the patients, because with, as you know, that the time that you spend waiting to have the investigations and then treatment, and plus age is not going to stop for that.
That's right.
So the more you do in primary care and better things are optimized, the quicker we can get on to treating the couple.
Yeah, that's helpful. We do quite a lot of things in the primary care, but definitely we don't cover everything. So it's a good explanation and good things to tell us. So that's help.
And sorry, one other thing to mention here is to advise them to start folic acid and vitamin D supplementation, because we still find, despite it being so much widely aware, people being widely aware of it, we'll have some small proportion of patients who wouldn't have started any of their preconception supplements. So that is absolutely important, that in the primary care that all is.
So we definitely start folic acid, not essentially we would have started vitamin D in a primary care, but definitely we are quite aware of the folic acid. But you would say vitamin D.
Yes, so vitamin D is the other preconception we advise. So 10 micrograms of it is essential for starting along with the folic acid.
Ideally, we tell everybody to take in winters, and especially in Scotland, and there's no sun.
Absolutely.
So now I know there are primary and secondary causes of fertility. Would you like to throw some light on that?
Yeah, so they're not called, they're kind of the types of fertility issues. So primary is when somebody has never been pregnant. Okay. Now it's related to the prognosis for the couple, because if they've never been pregnant, it's likely that they may have a condition, which is kind of more prevalent in them as compared to somebody who's got secondary. So secondary is where somebody has got pregnant, and it could be and irrespective of the outcome of pregnancy. Okay, so it could be that they have lost a pregnancy or haven't had an ectopic pregnancy or a baby born. So all of that is classified under secondary infertility. Now, prognosis wise, if you have been pregnant before, then your chances are better off as compared to somebody who hasn't got pregnant. Okay, so that's why it's kind of, kind of categorized into those two types, just to kind of guide us towards a prognosis for the couple.
Okay, so I think that's really helpful. Now, how and when should people seek help? That is the most important thing. Where we have touched a little bit about saying that age and all that. Is there any other things you want to add on?
Yeah, so one is obviously, as we mentioned, with the age, that, if you're trying for a year, having regular sex, sometimes, we have couples here who work offshore.
Yes.
And their partners may not be present in every cycle, but so their actual duration of trying and the duration, it will be less. So barring all those, if you have sincerely tried for a year and things haven't happened and you're under 35, you should present for investigation.
Okay.
The second thing is that if you have, or as I said, if you're over 35, then at 6 months you should present.
Okay.
But if you have a known condition where your periods are irregular, or you have a medical condition which can affect fertility, like in men, if you've had previous surgeries where one of your tubes has been removed, or your ovaries had been removed, or previously somebody has done a laparoscopy for diagnosing a gynae condition but found your tubes were not looking good and there was plenty of scar tissue. So these are kind of examples of the reasons that you may or your GP may know of. So in those cases, you have to be proactive and not wait until the first 1 year to send them. So you need to send them as early as possible so that we are saving that time.
So this is more for a GP to be mindful of and telling the patients when to go for
Absolutely. So this is because patients, if they're diagnosed with something like that, they're always told that, whenever they're planning fertility, to be aware. But obviously they may not always remember. So therefore, the second point is the GP who they present to first, that they can kind of look into the past medical history and see are there any conditions which can make them more prone to have these issues. So not then make them wait for a year and then just send. Or if the GP has done initial tests where they've seen, hormones are not good or they're not ovulating regularly, you send them straight away. You don't wait for a year. Okay.
Thank you so much. I think that was really helpful. A lot of information was put in that small time. We'll try to do another one with fertility and nutrition and fertility and lifestyle kind of podcast. But thank you so much for today.
No, thank you for having me. It was a pleasure.
In the next part, we'll dive into the lifestyle factors that can affect fertility, like nutrition, exercise, stress, sleep, and even environmental exposure. So whether you're planning to start a family, currently trying to conceive, or supporting someone through it, this is for you. Make sure to subscribe, like the video, turn on notifications so you don't miss the next episode. Bye-bye till the next time.